The ADA 2021 Standards of Care have just been released, and I'm going to discuss the key changes in the standards of care that I think are important. I'm going to go through the sections, but not all the sections, and really highlight the differences from the prior year's standard of care. So in section 1, we call it Improving Care and Promoting Health in Populations, and we really focus on the notion of understanding the social determinants of health for an individual patient, and encourage you to look at the scientific review that was recently published discussing social determinants of health in people with diabetes. Section 2 is classification and diagnosis of diabetes. And the big difference, at least in my mind, is that we now include LADA, latent autoimmune diabetes of adults. And LADA is kind of an oddball term because it's very commonly used in the general population. A lot of patients say, I have LADA, or providers, but we haven't really defined LADA. And so the key to LADA is that it's really an awareness that the patient is having an autoimmune beta cell destructive process, and that this can occur in adults and appears to be different than the process in children because adults can have a very long duration of marginal insulin secretory capacity and to look all the world like somebody with garden variety type 2, except they eventually become fairly significantly insulin deficient, and many will require insulin. So even though we call LADA a form of type 1 diabetes because it's autoimmune beta cell dysfunction, basically because the term LADA is common and acceptable in clinical practice, we don't want to say don't use it, but we basically want to say think about this as a process of autoimmune beta cell destruction. So those patients may need insulin sooner than others, and they may be at risk for the development of DKA, especially if they're stressed and or are on an SGLT2 inhibitor. Other changes in this section include discussion of other types of diabetes associated with prediabetes and HIV, as well as cystic fibrosis-related diabetes and how to deal with it. And finally, we discuss in more detail post-transplantation diabetes. In section 4, which is the comprehensive medical evaluation and assessment of comorbidities, we really sort of strengthen this section, add more in terms of overall health status, risk of hypoglycemia, and using the cardiovascular risk calculator to understand cardiovascular risk. We talk about low testosterone in men and how to approach it, and I think that it's been reorganized in a way that makes it more clinically practical when you're following it in order to understand what to do at each patient visit. Section 6 is glycemic targets, and we used to have a subsection that was entitled A1C, but now it's called glycemic assessment. And basically, this is in order for us to allow the use of other glycemic measures aside from A1C. So we look at things like time in range and GMI, time below range, time above range, as glycemic goals for many non-pregnant adults. And we're really trying to make sure that we avoid hypoglycemia, but manage patients in a way that's most effective. We also suggest an assessment of hypoglycemia that's somewhat more intense and occurs at every visit, and use that as a key feature in guiding our therapeutic treatment targets. Section 7 is a section that looks at technology use in people with diabetes, and there's a number of changes here. So in the past, we subdivided recommendations from between adults and children. So we gave different recommendations. And now we basically lump everybody together. So instead of saying adults should do this and children should do that, we basically say, when used properly, real-time CGM in conjunction with MDI and CSII and other forms of insulin therapy are a useful tool to lower and or maintain A1C levels and or reduce hypoglycemia in adults and youth with diabetes. So again, adults and youth are combined, and diabetes is just diabetes. It's not defined as type 1 or type 2, but that basically anybody who's on insulin who has diabetes can benefit from real-time CGM. We basically did the same thing with intermittently scanned CGM, and we say that it can be helpful for the treatment of people with type 1 or type 2, any kind of insulin-requiring diabetes in both adults and youth. We then say that you should use real-time CGM devices as close to daily as possible for maximal benefit in patients on multiple daily insulins or on insulin pumps. But we do subsequently say you could use devices intermittently, say in somebody with type 2 diabetes, where you're looking more for a sense of patterns rather than real-time management. And then we say intermittently scanned devices should be scanned at a minimum of once every 8 hours. Now, instead of looking at blinded CGM and sort of separating it out, we now call it professional CGM, as it's been called routinely, and we say use of professional CGM and or intermittent real-time or intermittently scanned CGM can be helpful in identifying and correcting patterns of hypo and hyperglycemia and improving A1C levels in people with diabetes on non-insulin as well as basal insulin regimens. So here we're basically saying you can use CGM as a tool for people who aren't on intensive insulin therapy, but basically who are on any therapy if you use the tool in a way to help make adjustments in their regimen. So this is really broadening the use of continuous glucose monitoring to include pretty much anybody with diabetes, but always with the notion that this has to be coupled with education and adjustments of medications if that's what's necessary. So when we look at what we consider important in terms of how we assess glycemia, we basically suggest that the ambulatory glucose profile should be the standard printout for all CGM devices. We talk about time in range and its association with the risk of microvascular complications, and that a time in range that is in the range of 70% or more is really an acceptable time in range for looking at patient management in patients who are reaching glycemic targets, as well as to target an A1C of less than 7%. We talk about skin reactions in the use of CGM, which is a real issue for some of our patients. So we wanted to update you in terms of information about what the cause of skin reactions is and perhaps how to help patients deal with them. We recommend that people with type 2 diabetes and other forms of diabetes, such as cystic fibrosis-related diabetes, who are on multiple daily insulin injections, could be treated with an insulin pump. So we're basically saying insulin pumps are a reasonable therapy for anybody with diabetes of any sort who's on multiple daily insulin injections and needs a change in their regimen. We then talk about systems that combine technology and online coaching, the sort of notion of the virtual diabetes clinic, and talk about that as well. That's the end of the recommendations on technology, and I'm going to pause here for a moment and then move on to section 9 in my next recording. Thank you very much for listening.